Hello, everyone. My name is Jim Douketis, and I'd like to welcome you to this evening's webinar on COVID-19 patient management, insights, treatments, and challenges. And on behalf of the faculty tonight and on behalf of Thrombosis Canada, it's my pleasure to welcome you. You're probably wondering why Thrombosis Canada is doing a webinar on COVID-19. Well, in fact, all of the faculty yes, have an interest in thrombosis, but we are also frontline clinicians and have looked after literally hundreds of patients with COVID over the past 2 years in a frontline capacity as family physicians, as ER physicians, and as hospital-based physicians. And in addition to our typical Thrombosis Canada membership, I also want to welcome as you can see from the faculty, Dr. Dominik Mertz, who is an infectious disease specialist in Hamilton, Ontario. And he is joined by Dr. Eddy, an ER physician in Calgary, Dr. Benjamin Bell, a general internist in Toronto, Dr. Alan Bell, family physician in Toronto, Dr. Lana Castellucci, an internist and hematologist from Ottawa, myself, and we also have input from another faculty member, Dr. Lauren Cameron, a family physician from Hamilton as well. So welcome to all of you on behalf of tonight's faculty. These are my disclosures that I wish to share with you. And I also wish to share that for this presentation, we received an unrestricted grant from Pfizer Hospital as an educational grant. Of course, there was no input by the sponsor on any of the content that you will see this evening. We also take very seriously the issue of mitigating potential bias, as you can see here. And you'll also see that this program is accredited by the College of Family Physicians of Ontario, of Canada, and the Ontario chapter for up to 1.5 main Pro Plus credits. What are the learning objectives for this evening? Well, it's as much about you having an opportunity to share your experiences, your challenges with the management of patients with COVID-19 as it is as much for us to share with you our perspectives. So we will provide a very state-of-the-art, up-to-date, and by that I mean as of March 22nd at 7 p.m. Eastern Standard, about the latest on how to best manage your patient with COVID-19. And as I mentioned, we'd like to share with you some of our kind of between-the-line insights, and also we welcome your feedback about some of the experiences you've had. Next slide. So the agenda really is a journey of the typical patient with COVID-19, and we'll start off by looking at it in the outpatient setting in patients who may have symptoms or are newly diagnosed with COVID-19, and those who are mildly ill and don't need to be hospitalized. And that, in fact, is where much of our discussion will focus on, is those patients who don't need to be hospitalized. And we won't be really covering too much the ICU care. So after dealing with the mildly ill patients, we will, of course, touch on and discuss the management of patients who need to be assessed in an emergency room setting, when patients can be safely sent home versus when they need to be hospitalized. And of course, we will go into the inpatient setting, and then finally, what to do in the post-hospitalization setting. So we hope you find this very useful and practical in the care of your patients. We know we're kind of all buoyed by the spring weather and the waning of the Omicron wave, but we also realistically know that this is something that we're going to have to be dealing with probably for a very long time. So with that, I'll hand it over to Dr. Alan Bell, who will talk about the patient with newly diagnosed COVID-19 presenting to a family physician office, but does not require ER visit. Alan.
Thanks very much, Jim. These are my disclosure. As Jim points out, I am a primary care physician dealing with patients in the trenches. Next slide, please. Why don't we get right into it and talk about Charlie? He's a patient who presented to my office. He's a 67-year-old auto mechanic complaining of fever, productive cough, headache, and myalgia of 3 days duration. He was not having any red flag symptoms, no shortness of breath, chest pain, or gastrointestinal symptoms. Charlie lives with his wife and an adult daughter. All are fully vaccinated, defined as 2 shots. In addition, they have all also had a booster dose of COVID-19 vaccine. He had a PCR positive 1 day prior to his presentation. He's got a few significant comorbidities. He's hypertensive, he's hyperlipidemic, he's obese, and he's got a 20-pack year smoking history under his belt. His current medications are perindopril and indapamide and rosuvastatin. Next slide, please. So what are the considerations that have to go through a primary care physician's mind when a patient presents with a clear story of COVID-19, perhaps hopefully mild illness? Well, first of all, we're going to have to consider isolation strategy, and not just for the patient, but also for the patient's family and any household, his household contacts, as well as any casual asymptomatic contacts. We have to consider whether or not he may require further investigations. How are we going to monitor him? When should he be referred to hospital? And what sort of follow-up care does he need? We have to consider treatment options, both in the anti-inflammatory realm, whether it's inhaled oral steroids, fluvoxamine, colchicine, tocilizumab, as well as specific antiviral therapies. And we have 2 currently available, remdesivir, as well as nirmatrelvir, ritonavir, known as Paxlovid, and perhaps another one on the horizon known as molnupiravir, or Lagivrio. And also we have SARS-CoV neutralizing antibody. The one that remains is sotrovimab, with activity against the Omicron variant. Next slide, please. So let's talk about the current isolation strategy. This is the 4th time we're giving this webinar. This is the 4th different slide that I've had to use in the time we have been giving it. It is very much a moving target. The current isolation strategies in Ontario, taken from the current Toronto Public Health website, tell us that the patient himself, if they are fully vaccinated, or a child under the age of 12 years, need to self-isolate for 5 days from symptom onset or positive test date, whichever occurred first. Those, however, who are not fully vaccinated and over the age of 12, or are immunocompromised, or have been hospitalized in a non-ICU setting, or are in a long-term care setting, these individuals need to self-isolate for 10 days from symptom onset or positive test, whichever came first. And those with severe illness requiring ICU care require 20 days of isolation. That's for the patient. Now, what about the household contacts? Well, that has loosened up very considerably. Self-isolation for household contacts is still required to be as long as the case itself, unless they are asymptomatic and have any one of the following criteria: a prior positive test within 90 days, presumably they will have ongoing immunity. They are over the age of 18 and had 3 vaccine doses, or 4 if they are immunocompromised, or they are under the age of 18 and have had 2 doses. These individuals do not require self-isolation. Now, if the individual is immunocompromised and does not fit into any of those criteria, then 10 days of self-isolation for those individuals is still required. What about asymptomatic contacts? First of all, who are they? Asymptomatic contacts are individuals who have been in direct contact with the infected individual at a distance of less than 6 feet for a 15-minute period at least, without masking. Now, these individuals, again, do not require self-isolation unless they are symptomatic, in which case they may well be a probable case and need to follow the patient isolation strategy. But they do need to monitor. It is recommended now in this day of optional masks that they do wear masks, and they avoid high-risk settings such as long-term care facilities, healthcare settings, and, of course, contact with vulnerable individuals. Next slide, please. Well, here is the latest Ontario science table recommendation for how we manage these patients. And they, first of all, require a determination of their risk. And they have simplified this into simply two risk categories: those with standard risk, who are considered to have a risk of hospitalization of less than 5%, as well as those at higher risk, who are defined as having a risk of hospitalization of greater than 5%. And you can see, in order to stratify those, we base it on parameters of age, vaccine doses, which is mitigated through risk factors, and also whether or not they are immunocompromised or pregnant. So for example, you can see on this table that an individual who is age 40 to 69 has had 1 or 2 doses of vaccine. We then want to go and take a look at the risk factors on the right side to determine whether or not they are at higher risk. You'll notice, importantly, immunocompromised individuals of any age and regardless of other risk factors are all considered to be at elevated risk, and they are indicated for active therapy. Next slide, please. So here are the treatments, and Dominik is going to follow my presentation with a little bit more detail on this. And I will point out that individuals who are over that 5% threshold, it is recommended that they receive specific antiviral therapy with either nirmatrelvir, ritonavir, Paxlovid, but it should be pointed out that these individuals need to start their therapy within 5 days of symptom onset, which is different from the other two therapies, the monoclonal antibodies, sotrovimab, or the antiviral remdesivir, in which case you can start therapy within 7 days. It should be pointed out that if they are going to go on I'm going to say Paxlovid, that the dose is 300 milligrams, or 2 of the nirmatrelvir tablets plus 1 of the ritonavir 100 milligram tablets. However, if they have renal compromise with an EGFR between 30 and 60, the dose of nirmatrelvir is reduced to 150 milligrams, or 1 single tablet in combination with 1 tablet of ritonavir. It's important also to realize that the ritonavir is in there not as an antiviral agent, but as an agent to inhibit CYP3A4 to prolong the effect of the nirmatrelvir. And of course, if it's going to inhibit 3A4, then it's going to inhibit all the other drugs that are metabolized through 3A4, and that needs to be taken into consideration. You know, for example, direct-acting oral anticoagulants, rivaroxaban and apixaban, both depend on 3A4 for metabolism, and their product monograph does indicate that they are contraindicated with the use of strong inhibitors such as ritonavir. Sotrovimab and remdesivir are also options, and the choice of which of these 3 drugs that is used is going to depend upon the ease of administration, the availability, contraindications, and other factors, but they do not specifically recommend one therapy, as far as I can tell, over the other at this time. If these drugs are not available, fluvoxamine, given as 100 milligrams twice a day for 15 days, or Budesinite, 800 micrograms inhaled twice daily for 14 days may also be considered, but are definitely second-line therapies. Individuals who are at standard risk, however, these are considerations. Most individuals at standard risk can do with simply reassurance and monitoring of symptoms, preferably with oxygen saturation. However, in individuals who you think may be at risk but don't quite fit into that 5% category, the use of fluvoxamine at the dose we just discussed, 50 milligrams titrated up to 100 twice a day for 15 days, may be considered, as may Budesinite, 800 micrograms twice daily for 14 days. Next slide, please. Currently recommended against are drugs that have shown no value or may be associated with more harm than benefit, such as antibiotics, monoclonal antibodies without activity against Omicron, hydroxychloroquine or chloroquine, ivermectin, and lopinavir, ritonavir, which are not going to provide any benefit and certainly can present potential harm. There are a couple of other therapies that are kind of on the borderline, not currently recommended, but do have evidence to support them, such as colchicine and interferon. Next slide, please. So the patient needs to be advised with regard to monitoring of any red flag symptoms, specifically what I like to say, trouble breathing. A lot of my patients would not understand shortness of breath. Persistent vomiting and diarrhea, which potentially could lead to dehydration. Red flags for that, of course, are inability to take fluids, syncope, reduced urine output. I like to provide a home pulse oximeter if I can to the patients that I'm a little worried about. I fortunately have a bunch of those in my office that were provided to me through the Ontario government. And any persistent drop, they should be informed of below 92%. Oxygen saturation should trigger an ER visit and will often trigger admission. We don't usually require any further investigations in these patients, and I like to follow them up after about 1 week. Next, please. I want to spend just a couple seconds talking about Budesinite and the principal study. This was a study that looked at 800 micrograms of Budesinite twice a day against standard of care and some other therapies in individuals who were over 65 or over 50 with significant comorbidities. They could be unwell for up to 2 weeks prior to entering the trial. Next slide, please. 4,700 people were randomized to one of the 3 treatments, either Budesinite, standard of care, or a few other treatments that are not adequately described in the paper. And the outcome showed that the primary outcome of time to first reported recovery is actually reduced by about 3 days in these individuals. And importantly, there was a 2% absolute risk reduction in hospitalization or death at 28 days. I will, however, point out that this did not quite reach statistical significance, but they did a calculation of the probability of superiority for this treatment, and it was 96.3% probable that it was, in fact, superior to placebo. Next slide, please. I will point out that for a while there was a bit of a shortage of inhaled Budesinite. And there is evidence for other inhaled steroids, specifically Ciclesinide at a dose of 320 micrograms twice a day for 30 days, which interestingly was quite the sort of the opposite. It did not show any reduction in duration of illness, but showed a very strong reduction, although it was a relatively small trial, about 200 patients per arm. It did show a 82% reduction in the risk of hospital admission or emergency visits, and that was statistically significant. So in the absence of Budesinite, if you want to treat a patient, Ciclesinide is probably an option, although not specifically recommended by the Ontario Science Table. Next slide, please. So how was Charlie managed? His family was, first of all, educated as well as himself regarding those red flag symptoms that I think we're all quite familiar with. He was instructed to isolate for 5 days. He was provided with a home pulse oximeter and told to make sure that he doesn't drop below, any persistent drop below 92. And although he did not fit the criteria for the elevated risk, I thought that his obesity, as well as his smoking history, as well as his other comorbidities and his age being, 67, not so far from 70, that I thought it was appropriate to treat him and gave him 800 micrograms of Budesinite to be inhaled twice daily for 14 days. Next slide. So that's the sort of top level view of what it's like in the trenches. To do a bit of a deeper dive, I will turn it over to my infectious diseases colleague, Dr. Dominik Mertz. Dominik?
Yeah, thank you so much, Alan. And I try to follow up on the excellent presentation you've just seen and provide you a little bit more background information. Next slide, please. So you've already seen this table here from the Ontario Science Table. That's how we are supposed to use the drugs or make a decision on the indication here in Ontario. And as Alan already mentioned, it's based on the risk of hospital admission. And that risk, as you can see on the next slide here, is based on this table, which is based data from BC. And what I try to do here, you see all the red boxes, and whatever within that red box would be 5% and more risk of hospital admissions. Among males, as you know, females have a slightly lower risk in terms of severe outcomes from COVID infection. But for males, you see that it's more or less reflected in that table. It's a little bit more simplified, I would say, in the table, so a little bit less granular, but easier to apply than if you were to work with the table you see here. And as you probably all know by now, when you're looking at a less than 20-year-old with 0 risk factors and then vaccinated, your risk for hospital admissions approaches 0, while in a 80+ patient, 3 and more risk factors, even if triple vaccinated, so even if boosted, you still have a risk of more than 10% for hospital admissions, and that's what's being reflected in the indications for treatment. Next slide. Now, these are the drugs I will touch on in a little bit more detail. You've already heard about Paxlovid. I will talk about Sotrovimab as a monoclonal antibody, Remdesivir, the Pine Tree study, and very briefly fluoxamine as well. Budesinite you've already heard about, which can be used in the higher risk category if the other drugs cannot be used, or for the standard risk if you feel, yeah, I would like to offer something for the patient knowing that they don't qualify for the more expensive but also more effective treatment options. Next slide. One issue that I would like to mention up front, because that's true across the board in the data that I'm going to show you, is that the data we have is first and foremost in non-immune, non-vaccinated patients, and typically high-risk patients that haven't been vaccinated and haven't had a previous infection. And we sort of generalized that data to the vaccinated population or patients with previous infections, without exactly knowing how big that remaining effect remains. But again, assuming that you have more than a 5% risk of hospital admissions, you may still have a large enough absolute risk reduction to justify those treatments. First, here, Sotrovimab, the one monoclonal antibody available in Canada that's still active against Omicron. This is the original study here that shows you an adjusted relative risk of 0.21, so roughly an 80% risk reduction in hospital admissions in patients who had been treated with Sotrovimab. Again, patient population here are patients with multiple risk factors and unvaccinated. Next slide. BA2 is taking up speed, as everyone knows at this point. By end of February, we were in Ontario at roughly 17%. Some data suggests we are probably at around 50% at this point of BA2. So it becomes important how well does Sotrovimab or the other monoclonal antibodies hold up against BA2. And unfortunately, it looks like, in particular, Sotrovimab gets another hit compared to its activity against BA1 or BA11, which had been the sub-lineages we had been dealing with so far in the Omicron wave. So here you see a factor increase of almost 50 for Sotrovimab compared to the original strain. However, it looks like Regeneron may become potentially an option again. The issue here is this is in vitro data, and we don't know exactly how this translates into in vivo data. So we continue to monitor and watch and see whether there's more data out there that gives us an idea of how effective these treatments truly are in the setting of sooner or later predominantly BA2 COVID infections. Next slide. Another IV options that you have that successfully reduces the risk of hospital admissions is Remdesivir. This is the Pine Tree RCT, published late 2021. And it shows a reduction in similar ballpark, as you can see, as for Sotrovimab. So here the hazard ratio of 0.13. So a reduction again in the range of roughly 85% here. They used hazard ratios, however, but just to give you an idea, probably same ballpark in terms of efficacy and hopefully eventually effectiveness in the population that we are treating. You can also see on the right-hand side, when you look at the Kaplan-Meier curve, that the vast majority of events, which here was hospital admissions or death from any cause, occurred within the first week after treatment. Treatment here was given within 7 days, which is probably what we've all seen. Typically after a week, if people go into that more inflammatory stage, as Alan already explained to you, and that's when we see hospital admissions being required. Of note here, they had 0 deaths in both groups, so the effect here is really driven by preventing hospital admissions, in which remdesivir was highly successful. Next slide. So in summary, sotrovimab and remdesivir for mild disease in the community, both are IV infusions which require an outpatient clinic setup, a formal referral process to make sure that you get the right patients into your COVID clinic. The data supports benefit in the non-immune population, and as you've seen, a very significant benefit. And as I mentioned, we are generalizing that to other high-risk population or partially immune individuals at this point, assuming that we still see a significant absolute risk reduction. Time window is up to 7 days from onset of symptoms. Supply concerns, currently not the case, so you can forget this. In the past, we had periods where we were short on sotrovimab, then we were short on remdesivir. Currently, we are relatively well stocked, at least in the province of Ontario. Next slide. As I mentioned, a couple slides on fluvoxamine or Luvox. This is off-label use, obviously. Fluvoxamine is a selective serotonin reuptake inhibitor, a drug that IV physicians would never have dealt with in the past. And the effect here is thought to be the immunomodulatory effect that this drug has that can, again, prevent that more inflammatory, more severe stage later in the infection. This was a very early, small study here, 72 and 80% patients in each group, respectively, published back in 2020, where it did show a significant reduction in clinical deterioration, which was the outcome in this study. Next slide. This was taken up, of course, and the larger RCT was conducted by a group that included people from McMaster University. Again, small minority vaccinated, so they had a few, but only a very small group that was vaccinated. So the data is first and foremost based on non-immune patients. They were treated with 100 milligrams BID for 10 days, again, started within 7 days of symptom onset. And as you can see in the table here, a risk reduction in the range of 30+% for the outcome here, which is, again, risk of hospital admission or longer stay in an emergency setting. So not as effective as the drugs that I previously showed you, but still a sizable effect, as you can see. Next slide. Caveats here is interactions that include the risk for serotonin syndrome with MAO inhibitors. The Ontario Science Table recommends to consider phasing to reduce the side effects, starting off with 50 grams once daily, and then to increase the dose to 50 to 100 milligrams BID based on how much side effects people might have had after the first dose. Duration in the trial was 10 days. The Science Table recommends to consider up to 15 days here. Next slide. Another oral option not yet approved and available in Canada is molnupiravir, Lagevrio. Only this one slide here because it's not as relevant. You may have heard about the trial very early. The interim analysis showed a quite significant relative risk reduction of 50% again for the outcome of hospital admission or death, with a reduction from 14.1% to 7.3%. In the full data analysis, at the end, the relative risk reduction dropped to 30%, first and foremost, because the event rate in the placebo group suddenly went down to 9.7%. So not exactly sure what happened in the control group there, but overall, again, 30% relative risk reduction, same ballpark as what I've shown you with fluvoxamine on the previous slide. I don't know by when this drug may be approved in Canada. I haven't heard any timelines. Next slide. In contrast, here, nirmatrelvir, ritonavir, or Paxlovid, and we finally have a peer-reviewed publication, came out roughly a month ago in the New England Journal of Medicine, before we had to trust the Pfizer to present the right data to us without having had the actual journal article. But now it's out there. This is the EPIC-HR, so EPIC high-risk RCT. And in those patients with high risk for progression, the study showed a relative risk reduction of 89% for hospital admission or death. So again, similar ballpark as what I've shown you for sotrovimab and remdesivir previously. And it also resulted in a 10-fold decrease in viral load, which may have a positive impact in reducing further transmissions. I showed you here the table with the figure with the subgroup analysis as well. And as you can see, the effect is quite similar across all the subgroups. It looks like in the older population, it's even more effective than in the younger population. The exception to this rule is if your baseline SARS-CoV serology status is positive, there's still a statistically significant effect, but it's just borderline, as you can see there. And at the very bottom, you see patients that have received monoclonal antibody treatment at the same time. And there, it seems like there might not be a significant effect anymore. So immunity certainly plays into the benefit of Paxlovid, and we are very curious to see how Paxlovid actually works in the vaccinated or otherwise immune population. Next slide. And the answer, okay, if we first talk about the drug-drug interactions here, already mentioned by Alan, this is just from the Sanford Guide screenshots. So there's a long list of drugs that you need to consider and make sure, if you are able to use Paxlovid in your practice, to make sure that you don't have any drug-drug interactions, or you need to manage them accordingly. Next slide. Going back to the question, what to do with those immune patients where we would be using Paxlovid at this point of time if their estimated risk is more than 5% for hospital admissions. The EPIC-SR, so EPIC standard risk RCT, will probably give us that answer. This is the summary here on what's known about EPIC-SR provided by the Ontario Science Table. And the bottom line is that the primary outcome, which was alleviation of symptoms, was not met in the interim analysis that have been shared. But it looks like there's a borderline significant effect on hospitalization, reducing the risk from 2.3% in that population, so much lower than what you would have seen in the control group in those higher risk patients, obviously, down to 0.7%, so a relative risk of 0.3. Which will translate into a number needed to treat of 61 patients. But again, not statistically significant, may just be a power issue. We are all looking forward to see the final results of this trial, which may change again how we are using this drug at this point of time. Next slide. So in summary, the new antivirals, nirmatrelvir, ritonavir, so Paxlovid, approved for use in Canada for 2 months now. Canada has ordered 1 million courses, originally also ordered 500,000 courses of molnupiravir, as I mentioned, not approved yet. Time window for these 2 options is up to 5 days from onset of symptoms, which can be very tight when you consider that patients typically wait a day or two until they feel like, yeah, I really feel under the weather, I might need to get tested, then they need to get tested, you need to get the results. So 5 days can be tight. The regimen, as Alan previously mentioned, is BID, a 5-day course for either of those two drugs. Next slide. I think Alan already covered this. So there's unproven or harmful treatments out there in the outpatient setting with mild disease, currently not recommended, are colchicine, interferon, dexamethasone, and tocilizumab. The last two being indicated for the more severely sick patients, and you will hear about that in the next presentations that we will see. And then we have a number of drugs that have been unproven in any setting. Ivermectin, just another RCT being published, I believe this or last week, again showing no benefit. So probably the last RCT we will see on this drug. Same for hydroxychloroquine, lopinavir, ritonavir, so Kaletra, an HIV regimen hasn't proven to be effective. Azithromycin, no effect. Vitamin C, vitamin D, and zinc, again, by itself, not an effective drug to treat COVID-19. Okay, that's for my part. Handing over to Eddy.
Thank you, Dominik. That was such a great overview. Good evening, everybody. I'm here to provide you with the emergency department perspective on COVID-19. And before I begin, I just want to acknowledge we're now 2 years into this pandemic, and it's not lost on me that the tragedy has been quite incredible in terms of what the effects have been on the patients who we've lost, the healthcare providers, and what toll all of the pandemic has had on the healthcare system in general. No relevant disclosures to tell you about with regards to this presentation. So let me talk to you about a patient who's come to the ER. He's 67 years old, unvaccinated due to strong personal beliefs. Omicron is still the dominant variant in the community. He's on he has hypertension, but not taking any medications, a normal BMI. And of course, as we've seen in many of these stories, he attended a small gathering 5 days ago and is now coming in with new sore throat and shortness of breath on exertion. He's a bit tachypnic, but the SATs are fine on room air, although he does desaturate with exertion. And we do a lot of exercise testing in the emergency department to see what happens to individuals in terms of their oxygenation when they exert themselves. So does this patient need to come into the hospital? Next slide. Well, there's been a mountain of research developing prediction rules and scoring systems based on large administrative data sets to look at whether we can identify those patients who need to come into the hospital. And one of the tools that has maybe floated to the surface as being the most widely predictive and validated, at least for emergency department use, is something called the Soar Score. It uses just a limited number of criteria. And as you can see from the list here, it relies on the predictors of BMI, saturation, age, respiratory rate, and stroke. And if we think back to our patient, really, he scores negative on all of these things, except gets 2 points for being in the 60 to 69 category. So that translates into a relatively low risk of in-hospital death. And to be frank, with the bed pressures that we have in Canada, there is very little chance that this patient is going to get a hospital bed unless there are extenuating circumstances. And there's reason to believe that there's unreliable follow-up or perhaps some other issues that would prevent him from coming back to the hospital if he gets worse. Next slide. So home management, how would we, if we're going to be sending this patient home, what is it that Dr. Mertz just reviewed that might be applicable to the ER setting? And honestly, the answer is that the number of options that we're using through the emergency department are diminishing, especially as we're going into waves where most of the symptomatology is relatively mild for the patients that are well enough to go home. There are a few exceptions, and I'm going to cover those and also focus my presentation very much on the fact that this is such a rapidly changing field. How do you keep on top of the information and know what the latest is in terms of what you should be doing? And you've heard some great resources around the Ontario Science Table. I'm going to cover some others. Next slide. So one of the ones that I think is really invaluable is a collaboration coming out of the Canadian Institute of Health Research and McMaster University, and it's called the COVID-19 Recommendations Map. It's free access, it's available to anyone, and what they've done in this project is not only cataloged all of the recommendations that you could possibly imagine relevant to COVID-19, and not just on treatment, but also on issues of masking, isolation, return to work, just the gamut of possible issues that you can think of, and they're all available within this website. Keeping on top of the primary literature is nearly impossible. What you need is a reliable source of information that is unbiased and will tell you what are the best recommendations given in a particular context, because a recommendation in one part of the world may not make sense in another part of the world. Next slide. So this is what the rec map looks like. You can see the incredible number of resources that are available, whether it be on screening, testing, diagnosis, long COVID, which is under the treatment and rehabilitation column. And you can see the matrix there looking at whether you're looking at in-hospital patients, the school setting, healthcare facility, whether the COVID-19 has been confirmed or suspected. And clicking on each of those buttons will bring you to a unique record that I'll show you over on the next slide from these 3,000 recommendations. So here is just the example for sotrovimab, which, by the way, we're using in Alberta. I had an update this morning. The points that have been raised about the difficulty and timing are well appreciated, because despite sotrovimab being available for several weeks and having a very slick system where PCR tests reported to people on their cell phone also advise them to call a number if they meet criteria for receiving this treatment, and the treatment is delivered by EMS teams, paramedics who provide the infusion at home. Despite that, the effort that has gone into that, we've only given out about 1,500 doses since the beginning of 2022 for patients who meet the criteria. So you'll see here on this record that not only do you see the bottom line recommendation on sotrovimab from the Infectious Disease Society of America, but also how they scored in terms of reliability, trustworthiness, and robustness of the guideline. And you see here that in terms of scope, rigor, and editorial independence, their percentage scores were very high. So this is maybe something that you might want to adopt in your setting. Next slide. So we've talked about the sotrovimab, and I've explained to you a little bit about the situation that we're in. So when we don't make these decisions in the emergency department, we have a physician on call for the province who will direct queries related to both Paxlovid and to sotrovimab, and we direct patients to that resource if we meet criteria. But as Dr. Mertz mentioned, many of the patients who test positive will not automatically consider the need for treatment until they get worse. And remember, the COVID pneumonia usually sets in 7-8 days after you're first tested positive and you have your first symptoms, and that's often too late. Next slide. And I have to question, we are using sotrovimab because it's believed to still be the one monoclonal antibody that's still effective in the outpatient setting in the Omicron and BA2 era, but still with the absolute risk in the current wave is certainly less than in the previous Delta wave. And so the number you would need to treat, if you do the calculation, may be much more than it was in previous waves where the risk of hospitalization was much higher. Next slide. So For the patient with significant respiratory symptoms, who's got that terrible hacking cough related to COVID, we will, of course, if it's available, recommend Budesinite. So that's essentially the only treatment from what's been discussed so far that we are considering in the emergency department for patients who are going home, especially if there's significant cough to their presentation. Next slide. You have the Ontario Council. I think another useful resource that you might want to consider is coming from Western Canada. The BC COVID Therapeutic Committee not only has created recommendations for what to give in these various contexts, the critically ill, the severely ill, and the mildly ill, but will walk you through what is now becoming really so essential in COVID assessment, which is to look at whether the patient is in a high-risk category and meets criteria for being immunosuppressed, and a very stepwise approach is offered there. Next slide. Next slide. So, I think we are clearly now, based on the wastewater analysis here in Calgary, entering the sixth wave. We are seeing an uptick in presentations. Unfortunately, over the weekend, I had a 95-year-old gentleman who was previously in good health, who presented on day 8 post-COVID positive test with quite severe hypoxemia and pneumonia. And much of my time in the emergency department is spent around the discussion with the family and the patient of goals of care and whether this patient is going to be a candidate for the intensive care unit or not. And we still have quite a situation where the virus is so rampant that about half of the hospitalizations we're seeing still require special isolation rooms, but are not actually directly linked to COVID pneumonia or to patients, especially elderly patients who are demonstrating some change or deterioration or can no longer go home or who have fallen and happen to be COVID positive, or appendicitis in 30-year-olds who also mentioned that they're having some mild URI symptoms and turn out to test positive for COVID. I think the good news, however, we know that there's been an uptick in BA2 cases in Europe, and this is worrisome and was felt to bode poorly for what's going to happen here over the next few weeks. The good news is, and this is just in the last few days, the case rates are falling in these European countries, which means, of course, that we still are going to get this sixth wave, but hopefully it's not going to create the same strain on our healthcare system as the other waves. Leave you with just one more thing. Next slide. Well, this patient returns worse and has to come into the hospital. Unfortunately, Mr. D did go home, and despite our best efforts and with good intentions, he came back. I thought I had a slide on the Alberta Medical Association patient resources. You can look it up on your time. I'll put it in the chat window, but I think I'm passing the baton to, next slide. This is the patient resource page. Feel free to look it up. It's freely available, and I think a lot of really good education can be found here that we would not almost certainly never have time for in most patient encounters in the emergency department. I'm glad to turn things over to Dr. Ben Bell, who's going to talk about inpatient management.
All right. Thanks to all those that have preceded me. It's a tall bill. I'm going to talk to you about pharmacologic standard of care for COVID-19 in patients. Next slide, please, Holly. These are my disclosures. Next slide, please. So the focus of treatment for outpatients and generally speaking, those who are earlier on in their disease are really primarily focused on the virus. So either antivirals or monoclonal antibodies that are going to stop the virus from replicating in our bodies. And of course, the best treatment is prevention, and so vaccination. So having your own endogenous antibodies is of course highly important. And I think, by the way, I'll just mention that we all know from the trials, but I think that has really been highlighted with the huge surges of cases that we're seeing across all of Canada. For example, in Ontario, we're estimating 15 to 20,000 1,000 cases a day. Yet our hospitals aren't overwhelmed with COVID inpatients, and perhaps Omicron and BA2 cause less severe illness, but the sheer number of them, we would have expected many more hospitalizations if it wasn't for a very well immunized population. And so I think the most important thing that we can all be doing is preventing patients from coming into hospital and encouraging our patients to become vaccinated, and importantly to get boosted if they haven't. So I was saying the pharmacology, the treatment up front is really focused on the virus itself, and to an extent that's also true for inpatients, particularly when they're earlier on in the disease. But as you'll see, the secondary effects of the virus, namely the huge inflammatory response that it brings on in our bodies, is also part of the focus for inpatients. So the pharmacologic standard of care for inpatients includes antiviral medication, in particular remdesivir for a smaller group of patients who are less sick actually. And then beyond that, we're really focusing on anti-inflammatory pathways with dexamethasone, with anti-IL-6 antibodies, and anticoagulation. Next slide, please. So we'll talk about each of these therapies in turn briefly. It was recognized early in the pandemic that the systemic inflammatory response to this virus plays a huge pathogenic role in why people get sick. And so what do we have in our armamentarium to treat inflammation that's readily available, cheap? Steroids. And so people started giving patients with COVID steroids pretty early on in the disease. And we've known for quite some time from good clinical trials that they're highly effective. So dexamethasone has become the standard of care for all patients who are admitted to hospital with COVID and are on oxygen. On the basis of this trial that was published relatively early in the pandemic. There were about 6,000 patients that were randomized to dexamethasone or usual care, and usual care really meaning oxygen, ventilation. And it was seen pretty early, and it was seen rapidly that in this population of admitted patients, dexamethasone indeed prevented death. There were some important subgroups in this trial, and it really spoke to how sick the patients were. The effect of dexamethasone was amplified the sicker you were. So if you were intubated and ventilated, the relative risk of preventing death was the highest, 0.64. If you were on oxygen only by any delivery means, the relative risk of death, if you got dexamethasone or didn't, was 0.82. But interestingly, if you were admitted to hospital but not on oxygen for whatever reason, and by the way, that's very common now. Lots of patients coming into hospital with COVID, as Dr. Lang was suggesting, but not on oxygen. So the elderly individual with fever, weakness, falls, delirium because of COVID, not with COVID, but I would say because of COVID, but not on oxygen because they've been vaccinated. That individual would actually not benefit from dexamethasone therapy. And there was a suggestion of harm with dexamethasone therapy in the individuals who were not on oxygen. In the entirety of this trial, the relative risk of death if you got dexamethasone and had COVID was 0.83. Next slide, please. So within these subgroups, there was a mortality benefit for ICU patients, and there were fewer days on the ventilator. On the ward patients, there was a mortality benefit, and there was a suggestion of prevention of escalation of care to requiring the ventilator. As mentioned, there was no benefit and perhaps a suggestion of harm in patients who are not on oxygen, so we don't use it for outpatients who aren't on oxygen and inpatients who aren't on oxygen. In the entire group, the number needed to treat was only 35 to prevent one person from dying, and it was even higher in the oxygen requiring cohorts. The dose of the medication is 6 milligrams a day for 10 days or until discharge. And the cost of it is $6.60 if it's given orally and $91 if it's given by IV. So a highly effective, relatively safe, and readily available treatment that all patients with COVID on oxygen receive. Next slide, please. We've already spoken about remdesivir, and the data for remdesivir, in my opinion, is strongest in outpatients who are not on oxygen and who are presenting early in their disease course. There's also evidence that, and Dr. Mertz talked about that data. There's also evidence that remdesivir is effective in hospitalized patients as well, but unlike dexamethasone, where the sicker patients benefited most from the drug, it was the opposite with remdesivir, where the least sick patients benefited most from remdesivir. And I think that's because remdesivir, being an antiviral, is most effective in the viral state of illness rather than in the targeting the host response. And by the time you're in the hospital on oxygen with COVID-related pneumonia, the biggest bang for your buck seems to be in targeting the inflammatory response, the host response to the illness. So in individuals who were not ventilated, less sick, remdesivir seemed to prevent death, although the 95% confidence interval just past the line of unity. That's kind of high. That's highlighted here in yellow under lower risk strata with no ventilation. And in the higher risk patients, so individuals who were ventilated or on high flow nasal cannula, those individuals did not benefit from remdesivir therapy. Next slide, please. So what is remdesivir? It's a nucleoside analog, and so RNA polymerase picks it up, but then RNA polymerase can't continue replicating the viral genome, so it stops viral replication. As mentioned, there's no benefit in those who are critically unwell. In the meta-analysis that I demonstrated on the previous slide, with individuals who are hospitalized requiring oxygen, there was no benefit regarding mortality or intubation, although the 95% confidence interval was right there. It may reduce time to recovery, but there's no change in length of stay. There's really no significant toxicity to the medication. Assuming the relative risk was significant, and I think it probably was, particularly on the basis of more recent data in outpatients, the overall number needed to treat was 143 to prevent one death. It's only given by IV, and it's given 200 milligrams on the first day and 100 milligrams daily for 4 subsequent days, and it costs $3,100 for a 5-day course. But I think remdesivir, we do use it for inpatients who are mildly unwell, requiring oxygen by nasal cannula. And I think that biggest bang for your buck with this drug is probably in the outpatient space, or those who are less sick. Next slide, please. So really targeting the host response. Now we're looking at a medication called tocilizumab. It's an IL-6 inhibitor. It's used for rheumatologic conditions. It's also used to treat patients receiving CAR T-cell therapy and complications therein. But as an anti-inflammatory medication, it's been found to be useful in patients, particularly with severe COVID. So this is, I think, the best trial of the drug. It looked at about 4,000 patients, all of whom were quite significantly unwell, elevated CRPs, on lots of oxygen, most typically high flow, and these patients were randomized to tocilizumab or usual care. Interestingly, at this point when this trial was done, usual care did not always include dexamethasone, although often did. And so what was found in this trial was that the individuals who received tocilizumab were less likely to die, with a hazard ratio of 0.86, and that's highlighted at the bottom in yellow. Interestingly, when given to patients who did not get concomitant dexamethasone, the treatment effect was lost, evidence of harm. And so we always give tocilizumab with dexamethasone. And in fact, as mentioned, all patients with severe COVID, with COVID on oxygen would get dexamethasone almost, I would say, without exception. And that's certainly true for patients who are getting tocilizumab as well. Excuse me. Next slide, please. So as an anti-IL-6 antibody, it targets the inflammatory cascade and inhibits cytokine storm. The largest study that I just showed a reduction in death and a reduction in the need for mechanical ventilation. It's a reduction in the need for dialysis. We give it to 25 people to prevent one person from dying. It's given 8 milligrams per kilogram in a single IV dose, and in times of drug shortages, which we actually had in Ontario just this past January, we were giving 400 milligram doses times 1, and it costs around $1,000. Excuse me. Next slide, please. In times of extreme drug shortages, which we also experienced not too long ago here in Ontario, there was no tocilizumab left. And so baricitinib, which is another immune inhibitor, has been tested in this kind of situation as well. This is a meta-analysis done by the Ontario Science Table, looking at the 3 largest trials for baricitinib in critically unwell patients with COVID-19, and the hazard ratio for death was 0.64 in individuals who receive this drug versus individuals who receive standard care. Next slide, please. And so this, so baricitinib is a JAK1 and JAK2 inhibitor, and so through that mechanism reduces cytokine storm, and there may be some direct antiviral effects to the medication as well, although that's probably much less important, as I've alluded to already, when somebody is this unwell. There are lots of studies of the drug. There's some conflicting results, but it seems that in individuals who are more severely unwell, these medications seem to work better. As mentioned, the Ontario Science Table meta-analysis confirms a mortality reduction and a quicker recovery at 2 weeks. You treat 33 people to prevent one person from dying. It's given orally, 4 milligrams a day for 14 days or until discharge, and it costs around $1,400. When there's a choice between tocilizumab or baricitinib in Ontario, the preference is to use tocilizumab, I think, because the data is somewhat more robust and strong. But in times of tocilizumab shortage, baricitinib can be given in its stead. Of note, both are not to be used, and of course, the selection is based on local availability. Next slide, please. So we couldn't talk about COVID-19, especially not a talk that's being put together by Thrombosis Canada without at least mentioning venous thromboembolism. As you know, COVID-19 is a prothrombotic state, probably related to the cytokine storm that it induces. And so what are the rates of VT with COVID-19? It's hard to define in outpatients, mostly because we don't know the size of the denominator, especially right now when we're not testing. But in previous estimates, it's been thought that the rate of venous thromboembolism, DVT, and PE in outpatients with COVID-19 is around perhaps 1 in 100, maybe a little bit less. In ward inpatients, it's 4 or 5 in 100, and in ICU patients, even higher, 5 to 10 per 100. Next slide, please. And so these observations of excess VTE than what we would otherwise expect with similar like illnesses, for example, influenza, pneumonia, led a lot of interest to investigating anticoagulants as potential treatments for COVID-19. And this slide's actually a little bit cut off the way it's been presented, but there have been in hospitalized patients 33 trials done in ICU patients and 50 trials done in non-ICU patients. And I'm going to highlight a couple of them. Next slide, please. So the multi-platform RCT is really, I think, the largest trial in the matter, and shows the most robust evidence. It broke patients down into ICU type care, being intubated, ventilated, or receiving high flow oxygen, and the non-ICU patient population receiving low flow oxygen. And they asked the question: is therapeutic or prophylactic anticoagulation with low molecular weight heparin better or worse. And what was found in the multi-platform randomized controlled trial, was that in the intensive care unit, prophylactic anticoagulation was better, and on the wards, therapeutic anticoagulation was better. Next slide, please. And with that, perhaps I'll just highlight. I did have a slide before on how these patients are treated. So I'll just highlight, briefly. Patient comes in, COVID-19 requiring oxygen. We would give them all dexamethasone. If they're on low flow oxygen, they'll also receive remdesivir. If they deteriorate, despite that therapy, so need more oxygen, get more unwell by any measure, and assuming their inflammatory markers are elevated, we would then proceed to add a dose of tocilizumab or baricitinib if there's a tocilizumab shortage. These patients would also all receive therapeutic anticoagulation, assuming they're at relatively low bleeding risk. These patients would all receive prophylactic anticoagulation, as all hospitalized inpatients would. And if they're at low bleeding risk and they're on low flow oxygen with COVID-19, they would probably receive therapeutic anticoagulation. If they deteriorate further, and they move to the ICU or require high flow oxygen, then the therapeutic anticoagulation dose, then the dose of anticoagulant would be reduced to prophylactic. And with that, I will move on and pass the torch to Dr. Castellucci.
Thanks so much, Ben, and thank you to all the presenters before me. Next slide, please. And next slide. So I'm going to follow Ben's management of hospitalized patients. And now we're going to transition to what do we do with medications that patients received during their hospital stay, and do they need to continue these medications once they're being discharged from hospital? And so going back to Eddy's patient, who was initially discharged home from the emergency department and unfortunately represented with hypoxia requiring admission to hospital, he's now been admitted for a few days and received some therapies in hospital such that he's ready to be discharged home. And as you're preparing his discharge summary and going through the EMR, you see that there's a number of medications that were used to treat him, and we need to decide on whether or not he's going to continue these at home. Next slide, please. And so I'll follow along Ben's line of thought here in terms of discussing dexamethasone, remdesivir, tocilizumab, anticoagulants, and recombinant antibodies, specifically sotrovimab. Next slide, please. So our patient was admitted to hospital due to hypoxia and requiring supplemental oxygen. And so as you heard, we treat for a maximum of 10 days for patients when they're in hospital. And when they are being discharged from hospital, there are two ways that this could be managed. Next, please. And what happens with patients who are being discharged home without supplemental oxygen is that their dexamethasone stops once they're discharged from hospital. Next, please. But there are some patients who end up being discharged home on supplemental oxygen. And we were doing this a lot, of course, when we had a number of patients being admitted to hospital with COVID-19. And frankly, we needed beds. And so we were using this as a way to facilitate discharge home if they were on low flow rates of oxygen, such as 2 to 3 liters per minute. And some patients, when they do go home, you may consider extending their treatment course of dexamethasone to complete that 10 days. Alternatively, we have seen a lot of patients diagnosed with cryptogenic organizing pneumonia who've had COVID-19 pneumonia. And management for this is typically high-dose steroids such as prednisone. And what we often did was stop their dexamethasone and transition them to high-dose prednisone in conjunction with a respirologist in consultation for follow-up. Next slide, please. So as Ben mentioned, remdesivir is typically given for 5 days in hospital, and it is only used either in the pre-hospitalization setting or the hospitalized setting and not post-discharge. So if a patient has only received 3 or 4 days of remdesivir, it would stop at the time of discharge from hospital. Next slide. And tocilizumab, as we learned, and same with Barry, both of these are given in hospital. There is no evidence to continue these therapies post-discharge. Tocilizumab is a single dose, whereas Barry is given for up to 14 days, but again, only during hospital admission and not post-discharge. Next slide, please. So anticoagulants has certainly gained a lot of attention in COVID-19 therapies. Low molecular weight heparin, as we heard, is the standard of care for moderately ill hospitalized patients. And so these are patients that are on nasal prongs, so low flow oxygen requirements. And the advantage for them is receiving therapeutic dose anticoagulation, and it reduces risk of progression to ICU level care. What we know is that the maximum dosing period for therapeutic anticoagulation is up to 14 days during the acute illness only. And this is something that would not be continued after hospital discharge unless there's another reason to continue it, such as the patient developed a DVT or PE, or, for example, if they developed atrial fibrillation or were on anticoagulants for atrial fibrillation. So really, we don't continue therapeutic anticoagulation post-discharge unless there's another indication to do so. Next slide, please. Now, some of you may have heard about the studies that are either ongoing or completed that have looked at patients who have been discharged from hospital after treatment of COVID infection. There's a study called the Active-4C trial, which is led out of the United States, and it's comparing apixaban 2.5 milligrams twice daily to placebo for 30 days in patients that were admitted for at least 2 days. And this is an ongoing study, but quite frankly, their recruitment is a bit slow, so we're not entirely sure if it will be completed. But short of that, there is another trial that was published in December in the Lancet called the Michelle trial. And this is a study that was done in Brazil in 14 centers, and it included 320 participants who had all been admitted to hospital for COVID-19. And patients were either randomized to rivaroxaban 10 milligrams daily or to no anticoagulant for 35 days. And they were stratified based on the improved risk score as well as an elevated D-dimer. Now, they had a primary composite outcome, which included a lot of things that are not intuitive to us. So it included things like symptomatic VTE, so symptomatic DVT and PE, but also asymptomatic DVT and PE. And so that meant that patients were getting screening ultrasounds and CT scans of their chest to evaluate for DVT and PE, respectively. They also looked at all-cause mortality, as well as arterial thrombotic events. And of course, because it's an anticoagulation study, the safety factor that they looked at was major bleeding. What they saw in this study was that while there was a significant reduction in the composite outcome, what I would caution you to do is really evaluate your patient on an individual basis. I don't think that we can safely say that a composite outcome that includes asymptomatic screening VTE done by CT scan and ultrasound is necessarily significant enough that we're going to use this for all of our patients discharged from hospital. My personal approach for this is if patients have had previous VTE, especially in a provoked setting, such as after surgery or hospitalization, then those are patients that I would consider higher risk for VTE, and I may prescribe them DVT prophylaxis post-discharge. Again, for a few weeks, 4 weeks is a reasonable strategy. Next slide, please. And then I bring up this slide with recombinant antibodies related to sotrovimab. So we learned from several of our speakers previous to me that sotrovimab is really meant to be used for patients pre-hospitalization. In my hospital where I work in Ottawa, we have had some patients receive this in hospital. And really it's patients who are admitted for reasons other than their COVID infection. And then they develop COVID in hospital. And so we have been giving patients sotrovimab in hospital, but again, this would be done only during hospitalization and not post-discharge. So that's the reason that I mention it here. Next slide, please. So before we move on to questions, I just want to go to the next slide and just highlight one of the things that we have for Thrombosis Canada. So when we had availability of Paxlovid, as you heard from all of us this evening, there are many drug-to-drug interactions that need to be considered, including the direct oral anticoagulants. And so this is a statement that we put out saying that this needs to be done with caution if you're going to use Paxlovid in patients that were receiving DOACs. And I'd invite you to also see our guide on drug-drug interactions, which you can see on the next slide, please. Perfect. And I'll hand it over to Jim for our question and answer period. Thank you.
Thank you very much, Dr. Castellucci, and indeed thanks to all the speakers for really a tour de force survey of COVID-19 as of March 22nd, 2022. There were quite a few questions from you, the audience, and in fact, many of those were already addressed by the speakers, but there are a few, I think, more general questions that I think would be worth touching on. And we talked about the spectrum of severity and how we're seeing generally less severe cases. One of the things that comes up a lot that perhaps we don't have the greatest handle on is the prognosis of patients with COVID-19, whether they've been in hospital or more often if they've not been in hospital, what is referred to colloquially as long COVID. And Dominik, I wondered if you could just share some general thoughts about your views about long COVID. I mean, we got questions about, should we be doing, neuroimaging? What if there's persistent cough? Any general thoughts or any advice you'd give clinicians or patients who may be asking about their risk of long COVID?
Well, thanks, Jim. And I think, as you mentioned, right, it's probably an area where we still have lots and lots to learn. Unfortunately, most studies that we have on long COVID don't have a control group. Some have. None of them that I've seen are like a proper inception cohort where you would start off with healthy people. You know what their baseline symptoms are. They may or may not get COVID, and you follow them along in terms of looking what the long-term symptoms will be. All of this being said, long COVID certainly exists. The question is how frequent it is, which symptoms are truly linked with or associated with that previous infection, and what are risk factors, right? Which patients are more likely to develop long COVID? It looks like people with more severe disease, older comorbidities, are more likely to have long COVID symptoms. So the same risk factors that you have for more severe disease translate into a higher risk of long COVID symptoms thereafter. And I think the other piece there, when we think about severe disease, ICU admission, then it's basically the picture that you would see in terms of deconditioning in any patient who would have been intubated for prolonged periods of time, regardless of whether it was COVID or any other reasons for that. So there's a lot of different layers to all of this. I think the good news is that even if you still have symptoms after 4 weeks, chances are that those symptoms will disappear in the months to come. Loss of taste is one that can last for up to a year and still disappear after that. So there's certainly hope for those people who have those prolonged symptoms as well. My usual recommendation is, and well, maybe first one last step back, it looks like long COVID symptoms can affect pretty much every organ. So there's not one specialty that sort of can cover all of them. And my usual recommendation is if it's someone with respiratory symptoms, they should probably best seen by a respirologist. If it's someone with ENT symptoms, loss of taste, if there's a specialist out there, it would be ENT to see them, and also make sure that there's no other treatable reason for the symptoms they would have, rather than just say, oh, you have had COVID a month ago, so that must be it. So you don't miss any other diagnosis. I think that's one of my key recommendations I would make for primary care providers. treat them based on the symptoms they have. Don't only say, okay, that was COVID, that must be long COVID. Make sure you're not missing anything that you would be able to treat, and use long COVID as an exclusion diagnosis in the end. And then reassuring the patient to some extent that, yes, we are still learning a lot about it, but it looks like there's a good chance that things will be improving in the weeks and months to come.
Thank you, Dominik. That's just an excellent summation. For yourself, or maybe even for Ben or Lana, we got a question from an audience member about whether there may be value of using an inhaled corticosteroid, in this case budesonide, for post-COVID cough. Perhaps, what we've seen previously in, post-viral infections that lead to bronchitis or bronchiolitis. Anybody want to comment on that from the panel about that, the role of that treatment?
So I can comment from personal experience, if I may. So when I had COVID a while ago, actually, I had a persistent cough afterwards, and actually a lot of dyspnea. That was very persistent. I ended up seeing a respirologist, and to highlight Dr. Mertz's point about not missing alternative diagnoses, I was diagnosed with asthma after COVID, which is actually now gone. That's kind of interesting. So the inhaled corticosteroid that I took following that, I found personally very helpful. I think that inhaled corticosteroids following other respiratory tract infections in the absence of obstructive lung disease, I don't think have been found to be overly useful. The individual who has influenza or RSV and is left with a cough but no wheeze and normal PFTs, I'm not sure that would be useful. I don't think it's a harmful therapeutic maneuver, would be my own sense, just to see if it helps. But I would certainly think about ruling out alternative causes like obstructive lung disease, of course, post-nasal drip, GERD, etc.
Yeah, thanks, Ben, for sharing your personal story. It's always resonating with all of us. But just sort of again on the topic of the spectrum of COVID and what we're seeing now in the kind of waning phases of the Omicron wave. Eddy, maybe from your perspective as an ER physician, you've been through all the different waves. What's COVID looked like, and what's been the spectrum that you've kind of encountered now in an ER setting?
Thanks, Jim. So something I just noted in the chat window, what we are seeing is patients coming in with very troubling symptoms who have not had COVID long enough to meet the long COVID definition. So they're coming to us with dyspnea and a normal chest x-ray and no wheezing. So unfortunately, I don't have data on the yield, but we are getting a lot of PE workups on these patients, and a lot of them will have positive D-dimers, and I don't think we have great guidance yet on how to optimally diagnose patients with suspected PE, and some of them will be having positive D-dimers as a result of the inflammatory process. So we are seeing a lot more CT imaging, and there have been pickups, of course, but most of these tests are coming back negative. Otherwise, what's reassuring is that it's relatively rare to see the bombs of exploded lung tissue that we would see in the Delta wave in generally healthy 40 and 50-year-olds. We are certainly seeing COVID still coming into the hospital with hypoxia, or has been noted without hypoxia, and other general deterioration types of profiles. But when it comes to hypoxemic lung disease, that is still occurring, but it's generally in people who are elderly. And, it's just in some people, it's just a very debilitating infection. They are getting, that feeling of being hit by a bus, quite severe myalgias, and just not able to function for several days. But as you can imagine, in an emergency department, and with all of what we're hearing in the media about COVID, we're seeing a whole range of presentations, including people with anxiety and concern about what the implications of having a positive test are. So, primary care is not always able or willing to see these patients directly because of the infection risk. So that has created a significant burden on emergency departments. Hope that helps answer the question.
Yeah, very much so. No, thank you. I mean, it's always important to have that perspective from the ER. You mentioned that your colleagues may be doing a lot more CT scans looking for PE. And Lana, I know that in the hospital setting, we're probably have a lower threshold to ordering CTs on our COVID patients that might desat. And then, guess what? We find a pulmonary embolism. So one of our questions was, how do we deal with these COVID-associated DVTs and PEs? Is the treatment any different? Duration of treatment? Just your thoughts on that.
Yeah, thanks, Jim. This is a very common question that we've had right throughout the pandemic over the last 2 years. And I think as we've learned more about this and had more time to think about how do we treat this, it's really the same standard management that we would for any other VTE. In hospital, I tend to use low molecular weight heparins, and then at discharge transition to a direct oral anticoagulant. In terms of duration, I think all of us are pretty comfortable considering this as a provoked event, and so typically treat patients for about 3 months, especially if their clot developed when they were in hospital. For patients that are outpatients and have more mild disease, sometimes I do hedge on a longer treatment course of up to 6 months, because if they haven't been relatively immobilized or bedbound and things like that, the way that you would have a hospitalized patient, I tend to treat them a bit more on a weekly provoked path, if you will.
Okay, thank you very much. So I think we're almost at the end of our session. We hope you found the session valuable to you in helping to manage current and likely future patients with COVID. We'd also like you to think about supporting the work that we do at Thrombosis Canada with activities like this, and our website and an array of other resources for clinicians, all healthcare professionals, patients, and their families. We are a registered charitable organization, and if you can consider in your charity-related donations to think about Thrombosis Canada, we'd be most grateful. With that, I would like to thank the faculty for their superb presentations this evening, the organizers, once again, the support from Pfizer Hospital, and most importantly, I'd like to thank you, the audience, for your participation and for your questions. And we hope to see you again in another educational program with Thrombosis Canada. And we hope you have a pleasant afternoon or evening wherever you are in Canada. Good night.